I'm going to cut my image out. Hi, this is a brief video about the use of a ventilator. We will be going over the basics of the lung, anatomy and physiology. We'll be showing you how to set up a ventilator, and this is designed for people who don't have much experience using ventilators. In the current crisis, it is possible that you may be called upon to work with a ventilator and design a safe way of ventilating a patient to save their life. I am Dr. Haranath.
And I am Dr. Swarna Deepak.
We are both at Apollo Hospitals in Hyderabad, and we're just going to put our masks on and we'll continue talking. So, as you know, the human lung is pretty big. If you stretch the human lung out, it stretches out to 75 square meters, which is actually the size of a tennis court. The lung's job is to get oxygen in and blow carbon dioxide out. The oxygen comes in from the atmosphere at 21%, and if you need somebody with a low oxygen to get oxygen into their lungs, you have to sometimes increase the oxygen delivered, and that is called the Fio2, or fraction of inspired oxygen. So you have to raise the percentage. So the air goes into the trachea, and then it splits into two into the bronchi, then splits again 23 times to go into the alveoli, which is where the gas exchange occurs. I'm sure most of you already know this. So Deepak, can you tell me what are the main reasons somebody can go onto a ventilator? What do you think are the reasons for that?
As you know, the ventilator only supplements either the requirement of oxygen in the body or washing out of the carbon dioxide. So the causes usually would be either neurological causes where the patient cannot take their own breathing, or the airway is compromised because of various reasons, or because of neuromuscular disease, or in this present scenario most probably because of lung infections. So are systemic causes where the patient is much sicker and requires a ventilatory support. So these are the usual causes where we keep the patient on ventilator.
Excellent. So essentially, whoever needs a ventilator has a difficulty in getting oxygen in, carbon dioxide out. If somebody is not breathing, is breathing ineffectively or breathing very low and not able to take a full breath, or the lungs are filled with pus, blood or water. Pus meaning pneumonia, water meaning congestive heart failure, or blood where there is bleeding in the lung. In ARDS, which you might hear about in another video, where the lung itself has a lot of inflammation and products inside the alveolar sac, air and oxygen and carbon dioxide cannot exchange. In that situation, you can use the ventilator to adjust some of the settings. So this is a basic introduction on what a ventilator does. If a person cannot breathe, the ventilator is going to supply air and take the carbon dioxide out. This can be done through a tube that goes through the throat, and it is called the endotracheal tube. And you can confirm the position of an endotracheal tube by taking a chest X-ray and listening to the lungs on both sides. So we're going to quickly go through what the ventilator does. So the human lung, when you breathe, the air goes in, the air comes out, and that is what is called the tidal volume. The average lung size depends not on the weight, it depends on the height. A 5-foot male is 50 kilos, a 5-foot female is 45.5 kilos as the ideal body weight. For every inch on top of that, it is 2.3 kilos that you add. So Deepak, if I had a 5'8" male, what do you think would be the tidal volume you would want to set for this patient?
As you rightly said, we usually calculate the ideal body weight and the tidal volume expected. So we usually keep it around 6 to 8 ml per kg body weight.
Okay.
So it comes to around 500 ml to 460.
Sure. So exactly, you can do the quick calculation. The 5'8" adult is about 70 kilos is the ideal weight. Clearly, none of us are those weights. But when you have a 70 kg, you multiply by 6, 420, multiply by 8, 560. So you want the tidal volume in that range. The reason to do that is to protect the lung, to avoid it from distending too much or collapsing. So you can see this number here. Deepak, do you mind demonstrating how to change the tidal volume? Then we'll go back to what the settings need to be changed. Please show me that.
Yes, as you rightly said, we have some settings here. So these are the curves and these are the settings. So this is the tidal volume which we are talking about. So how much the lung gets the fluid, the air, and again how much it exhales. So you can, with this knob, this is a MAC ventilator. So in this one, the knobs are here. So you have a knob here, either you can increase, as you can see, you are increasing slowly, or if you turn towards the opposite side, you can decrease it.
Deepak, but is my patient going through this right now?
No, we have a test lung.
Oh, right, we forgot to show you this. This is a test lung. So a test lung is essentially a balloon. It's going to expand. And Deepak, do you mind increasing the rate? Make it really fast so people can see what we're talking about?
Yes, this is the respiratory rate. So if you increase it, so as you see, increase it to 21. So
let me push it to 40. Let's see what happens.
So you can see the test lung, it breathes rapidly.
Correct, and you can see the waveforms here. So this is your flow rate, air going in, air going out, as well as the pressure that is generated. Let's slow it down again. Excellent. So you've seen this mimics what the human lung does. You can see the air coming and going. And when you look at the parts of a ventilator, you want to make sure you have all the right tubings. You have a port where the air comes in. It's called the inspiratory port. The air comes in, and then the air comes out in the exhalation port. We don't have it here, but you should be having filters to prevent bacteria and viruses from getting contaminated into the circuit. So we have shown you already what the volume does. We showed you what the rate is. Normal rates, you can start at 18, 20. It depends on what you want to do. Same thing, human body pH 7.4 is normal. If you get too much carbon dioxide because you're not breathing, carbon dioxide goes up, pH goes down. 7.3, 7.2, etc. That can have bad effects on the body. How do you adjust it? You blow out the carbon dioxide. How do you do that? You increase the rate. The next concept we want to talk about is the Fio2 or oxygen. Do you mind telling people what the oxygen should really be?
Yes, see, it depends on the age of the patient and the lung of the patient, how much the baseline oxygenation. So we usually aim to keep it around the saturation. We actually calculate in the PaO2s, or you can keep a pulse oximeter and see the saturation on your monitor. So we usually start, as it was discussed, 21% is the room air FiO2. So we usually increase it in the multiples of 5 or 10, depends on the patient situation. So you can see here we are increasing up to 51, 53. So you can decrease it. The minimal saturation usually in a sick patient we keep is around 60%. So after that one we will assess.
Great. So if you remember, you may have heard about it. There's something called the SaO2 O2 dissociation curve, where the oxygen in the blood, PaO2, which you see on an arterial blood gas, when you take an arterial sample, you check the oxygen level, carbon dioxide level, and pH. So when you look at the FiO2, your saturation, which you check on the finger, can be anything from 90, etc. In an ARDS patient, we want it 88% or above, somebody with bad lungs. In general, 88% is good. Recent studies have shown maybe 94 to 98% in this current epidemic. If you keep it, the mortality is less. But essentially, you don't want to give too much oxygen because oxygen can also be harmful. So you've adjusted the oxygen. The next concept, which is probably most important, is the concept of PEEP. So let me give you an example. I'm sure all of you have blown balloons. When you blow a balloon, you need to initially put a little bit of force, and then it gets easier to blow the balloon open. So imagine you have 3 balloons. One is a normal balloon. One is a balloon made of iron. Another one is a balloon made of, say, just a little thin material like a bubble gum. In a bubble gum balloon, you blow and it just expands easily. Imagine your balloon was made of iron, and blowing and blowing and blowing, it's not going to open up. So this is the concept of lung compliance. Lung compliance is change in volume to change in pressure. So if somebody's lung is not compliant, meaning it's very stiff and not able to open, like in ARDS and other conditions, you have to put more pressure. In that situation, you have to increase what is called the PEEP. PEEP stands for, Deepak?
Positive end expiratory pressure. So which means that, as it was told, how much is the end expiratory positive pressure? How much is the pressure which is keeping the alveoli and the minor airways open?
So that's right. So just as we were talking about the balloon, you blow it open. I'm sure all of you have blown it. If you don't keep pushing air in, it's going to collapse. So that is your positive end expiratory pressure. I blew the balloon of the lung open, and I want to keep it open, so I keep pushing a little bit of air pressure in. If the lung is very stiff, it's going to try to collapse back, so I have to keep increasing the PEEP. So that is the concept of PEEP, and you can increase the PEEP. There are standard tables which tell you how much PEEP you need to put for how much oxygen level that you want. These standard tables may be even as high as a PEEP of 24 for somebody whose oxygen level is quite low. What was that noise? Can you tell me what the noise was?
We have the alarms here. So this respiratory rate into tidal volume is what which gives you the minute ventilation. So minute ventilation is how much is the ventilation which is going through a minute. So you have an alarm limits. We'll go through the alarm profile again.
Sure.
So I am just silencing the alarm here.
Great.
So
excellent.
Because we have set it around 4 in this case, so if it is coming down, it is showing as a red alarm.
Sure. So we have talked today about normal lung anatomy, normal lung physiology, why you need to ventilate a patient, how do you ventilate a patient, basic settings of minute ventilation, which is rate and tidal volume, how to calculate the tidal volume. We talked about how much oxygen they need. We talked about why you need to change the settings, why people need PEEP, and now we're going to talk about 2 final concepts. One is the concept of auto PEEP. Auto PEEP is where air goes in but doesn't come out. In somebody whose lung, where the lung is able to push the air in, but then it closes up in various areas, the air gets trapped and then you end up with something called auto peep or intrinsic peep. The way you find that out is you measure something known as the
end expiratory.
End expiratory hold. So I'm going to push this button here. So when you do that, you get something called the total peep. The total peep is where your complete air coming out is exerting pressure on the device, and you can measure what that number is. If that number is high, it means that the patient has air trapped inside. The last concept is of plateau pressure, and the plateau pressure is something which we do when we hold the lung in inspiration. So I'm letting the air go in and not letting the air out, and when you take this next button here, you see the plateau is 25. So you want that number to be below 30 in an ARDS patient. In most patients, you want it to be below 30. And we do all the settings of the ventilator based on these 6 or 7 concepts. It's fairly easy. The other things you need to really know about is how do you handle the alarms. Deepak,
Yes.
would you like to tell us about the alarms?
Yes. Whenever you are starting a ventilator, sorry,
Let's
just
do that.
silencing this alarm. So when you are starting a patient on an ventilator, so your basic goals are, have you set the, as you understood the patient, so is your connections good? Then you come to your machine. So in the machine, first thing is alarm profile. It should never be neglected. It is the most important thing. So you have alarm profile. So here we can see one is a pressure alarm, minute volume alarm, respiratory alarm, and end expiratory pressure alarm, which shows the pressures inside, just like any Peep. Okay. So here we have set around 40 is the upper value. So once your pressures goes up above the 40, then the ventilator shows you an alarm. So it could be like a tube block, or it could be because of clot, maybe a clamping of your ET tube. So
Maybe a collapsed lung could do that too?
yes, sometimes it could
Like
collapse.
a pneumothorax could do that too, right?
Yes. So
Okay.
whatever may be the cause in the lung or in an airway, it increases the pressure. So it causes the increased pressure. In an acute setting, if the pressure increases suddenly, then you need to understand what is going on with the patient. So second thing is the minute volume. So basically you have an lower limit and an upper limit. So whatever may be the causes, you can actually understand, depends on the alarm. Respiratory rate is again how much is the setting you are keeping and how much is the patient generating.
And I think right now let us switch to this last concept which we haven't talked about, which would be about the concept of the mode of ventilation. You see this thing here, it says volume control. When I press that button, I have a huge choice of how to make the patient's air go in. Remember, a ventilator is just an air pump. You are designing how much air goes in, how fast, over how much time, how many times a minute, with how much oxygen and what pressures. So the machine is smart, but it's not smarter than you. You are setting the machine settings. And when you choose the mode, volume control is, the word control means you're setting something in a fixed manner. So you can set the volume in a fixed manner. There are advanced modes of ventilation which include pressure control, where you set the pressure to a certain limit so that the pressure will determine how much volume comes down. So that's a little more advanced, but it's something you may need to learn about in an ARDS setting. You can learn about it later in the time that you're given to look at the other videos. Briefly, there's something called pressure support or Cpap. This is where the machine helps the person take his own breath. In other words, to generate a breath, you need a negative pressure in the pleural space, but when you're on a machine, you're having a lot of positive pressure going in. The machine will sense how much the patient sucks the air in and give the air breath in. But you can make it easier for the patient by giving them some extra pressure so they don't have to suck in much air. The machine will deliver the whole breath. So we talked about the modes. This is a very basic video showing you what the modes are. There are obviously much more detailed things we need to talk about. The one other concept you can talk about, I think, is the inspiratory to expiratory ratio. And the concept there is, imagine somebody breathes 20 times a minute. That is 20 breaths in 60 seconds. So one breath is about 3 seconds or so. So when you have a 3-second breath, you have the I to E ratio. In other words, you get the air in over 1 second, you breathe out over 2 seconds. Deepak, what would be a setting I would need to change that to a different number? What do you think we would do?
So usually we're concerned more about in a patient of either a stiff compliance like ARDS patient or in a COPD asthma patient, where we need more expiration to exhale a carbon dioxide, or we need to equate the inspiration and expiration, we need more oxygenation rather than, so it depends on your patient.
Sure. So essentially, you can adjust how much time you spend in breathing in, how much time in breathing out, so that if you want the carbon dioxide to go out, you give it a longer time. You can also use that to prevent auto-peep, which we talked about earlier. So this is an extremely basic video showing you what a ventilator does. We've gone through the physiology of the lung. We talked to you about the basics of setting it up. And I think if you have this much knowledge, you probably will not do harm in using a basic setting. Obviously, kindly consult with your local intensive care doctor, anesthetist, internal medicine doctor, or remotely through whoever is supporting you with using a ventilated patient. And remember, the connection should always be connected. If you are dealing with an infectious patient, make sure that you have complete positive protective equipment to make sure that you are completely protected. You also need to make sure that the aerosols generated are not in your space. You need to wear an N95 mask as well as complete donned personal protective equipment. So this is the basics we have talked about a ventilator. Thank you very much, and we will be giving more videos and more information as time goes on.
Thank you.